the colleagues who are here participating. Greetings from MGM Healthcare Channel. Today's topic would be rational usage of antibiotics in liver transplant recipients. As we know, in liver transplant, the commonest causes of mortality and morbidity are infections. Infections are a great nemesis. So the knee-jerk reaction of every clinician, whether at the district level, state level, or at the city level, or a transplant clinician, used to use the most advanced antibiotic and most number of antibiotics and the longest duration possible, whatever may be the underlying reason, for fear of losing the patient. In this, what happens is, today we are comfortable, tomorrow we are left with nothing. Unless we rationalize our usage today, tomorrow we won't have anything left with to save these patients. That's the basic idea of my talk, how to rationalize the usage of antibiotics in liver transplant recipients. Infections in liver transplant recipients are the significant causes of mortality and morbidity. The knowledge of the timing of the infection, and the predisposing risk factors help in the early diagnosis and timely intervention. Commonly reported post-transplant infection rate is close to 30 to 50% in overall, and bacterial infections account for the most of the infections. The commonest bacterial organisms include gram-negative bacilli and aerobic gram-positive organisms. If we keep up with trends in the epidemiology of these infections, the resistance patterns, the sensitivity patterns, the prophylaxis patterns, and the management, we can achieve good outcome. Emergence of antibiotic resistance is a major threat to global public health. It's not only caused by increased usage, but also by inappropriate use. In 70s and 80s, a lot of antibiotics are in the pipeline. Unfortunately, in this decade, we have very few in the pipeline also. The repercussions of antibiotic resistance include increased mortality, huge financial cost, prolonged hospital stay, and when we have MDR and hospital-acquired infections, there are only limited effective therapy options. So when a patient comes to my clinic as a chronic liver disease patient or to anybody, before starting antibiotics, I have to ask myself a few questions. Does this patient really has an infection or a non-infectious process more likely? It's often habitual for any isolated fever or some abdominal pain or some tachycardia. One-off instance, we start antibiotics for any chronic liver disease patients. For also example, you have dyspnea with some imaging changes. The causes could be various. You can have a pulmonary embolism or a viral infection or atelectasis, which don't need antibiotics. Or when you have some asymptomatic bacteria, 10 power 3, 10 power 4 cultures, you tend to start antibiotics. These are the conditions where even without antibiotics, the patient get better. Of course, if the patient has infection associated with clinical signs like raised TLC, fever, hypertension, you have to start on antibiotics. And any history of spontaneous bacterial peritonitis, you have to start antibiotics. And anybody showing any signs of infection has to be thoroughly investigated rather than blindly putting on antibiotics. You have to do the blood culture, urine culture, abdominal fluid culture. Then only you can do a proper justice to the patient. And whenever somebody is on the waiting list, it's not a very good plan to put high grade antibiotics and get on with the transplant. It's often prudent to suspend from the waiting list, treat these antibiotics, treat with antibiotics, and settle the patient, then take up for the surgery. Especially if a patient has a multi-drug resistant infection, it is important to consider a multidisciplinary meeting on a case-by-case basis, whether this patient is fit enough to undergo a transplant. In the post-op period, if he gets into a severe multi-drug resistant infection, can we salvage him? If the entire team feels we can salvage him, we can take them on case-by-case basis. But if we start doing most of our cases like this, then we will end up with nothing. Few words about empiric therapy. Whenever, a lot of times in liver transplant, whether in the pre-op or the post-op settings, you won't have cultures and the patients may become sick. And you have to start antibiotics empirically. You can't wait for the culture reports often. But few points have to be kept in mind whenever you start empiric therapy. Before starting empiric therapy, you have to send cultures because prolonged antibiotic therapy can result in resistance with inadequate response. And also, when you have a positive culture for a narrower spectrum antibiotic with less toxicity, you can do with that rather than going to a broad spectrum antibiotic and have wider resistance. The administration of empirical antibiotic therapy primarily depends on three things: patient risk factors, what's the severity of the illness, whether it is without sepsis or with sepsis, and what's the site of infection. The risk factors for patients include old age, higher MEL score, catheterizations, prolonged hospital stay, acute liver failure, any previous infection or prolonged ICU stay. The surgical factors often include long surgery, huge blood loss, massive transfusions, retransplantation, re-explorations. Postoperative risk factors include mechanical ventilation, whether we are using induction therapy, any complications of the surgery like PNF, HATs, PVTs, or biliary complications. Biliary leaks, ischemic cholangitis often form a significant cause of post-transplant infections. When we analyzed our data in post-transplant recipients, the commonest site was found to be abdomen in 42%, followed by blood in 34%, respiratory tract in 12%, and multiple sites in 6%. It is important to know the sites, the isolates of your own hospital. It will help you in deciding the exact what antibiotic to be used. The antibiotic used in some other center or some other geographic area may not work well for you. The commonest isolates in our country are especially negative bacilli. Even in gram-negative bacilli, the spectrum has been evolving over years. Recently, Klebsiella is gaining predominance because of the multi-drug resistance, E. coli, Acinetobacter, and we are seeing a lot of Pseudomonas as well. Gram-positive cocci only account for 24% in Indian settings, where it is much more in Western settings. So it is important to use according to our local settings rather than go by traditional Western antibiotic prescriptions. For every hospital, a local antibiotic policy is mandatory. We have to very judiciously use the restricted antibiotics like vancomycin, colistin, linezolid, because a lot of infections like UTI or community acquired pneumonia, no need for empirical vancomycin. And also in patients who have low risk factors, you can start with a narrow spectrum antibiotic in pre-transplant settings. And definitely we should avoid double gram negative coverage of antibiotics. Whenever we start antibiotics in the post-transplant settings, every day you have to have an antibiotic timeout and the rounds with the sisters, ID specialist, your staff and everybody. And whenever you can, you should try to stop these antibiotics. And you should have definitive targets, predetermined targets. This is what the general target is. If the target is achieved and the patient is better, we'll start. If there are no objective targets, a lot of subjective feelings, then you can have wide variations in antibiotic policies. It's better to have objective targets. Now we would see certain specific settings in transplant patients, whether in the pre-op or in the post-op. Spontaneous bacterial peritonitis, there is no need to start with a meropenem or a piperacillin tazobactam at the start. Even a cefoperazone or cefotoxime often works well. But you have to be careful in using fluoroquinolones if already they have been used. Generally, we avoid aminoglycosides for risk of renal toxicity. For other infections like pneumonia or UTI, it's important to use local epidemiology rather than using a fixed antibiotic. When the patients go for surgery, it's important to decolonize for colonize for MRSA. Contact isolation is very important for VREs and MDR gram-negative bacilli. The commonest antibiotic prophylaxis we use is either Magnex or cefoperazone sulbactam or piperacillin tazobactam, only for 48 hours just before the surgery. We don't have to use the higher carbapenems or the colistins for a lutein low risk patient. It's important to have cotrimoxazole to cover the opportunistic infections. And how we do post-transplant microbiological surveillance. We should have a routine practice of picking up these infections early, especially we have to do site-specific colonization studies for this ESBLs and VREs. And if somebody coliform resistant producing in the rectal culture, it's better not to use the carbapenems, and you can use for a ceftriaxone sulbactam or some antibiotic like that. Often, microbiological surveillance on biliary fluid is undertaken, but it's not mandatory. Whenever we are using IV antibiotics, we have to see whether the oral bioavailability is good. After ruling out severe sepsis, shock, or disorders of GI resorption, as soon as possible, we can start oral drugs, especially medicines like linezolid, metronidazole, fluoroquinolones, or fluconazole. When we look at surgical site infections, it is often multifactorial. It depends on what antimicrobial prophylaxis you used, what are the risk factors for this infection, and also the local patterns. Whenever you suspect an intra-abdominal infection, rather than jacking up the antibiotics, you should do a source control. Try to do source control in the form of get a CT scan done, culture of the ascitic fluid done before jacking up the antibiotics. If there is a bile leak or a perforation, you suspect it, you can do contrast CTs or bile leak studies like MRCPs. You have to do source control at the same time while upgrading the empirical antibiotics. And as soon as the cultures are available, we should shift to culture-based antibiotics. Targeted therapy is most beneficial. Whenever we have post-transplant pneumonia, we have to have 2 sets of blood cultures and the tracheal culture if the patient is intubated or tracheostomized. Generally, when the patient shows improvement, you should stop the therapy in 7 to 10 days, not prolong for 2 weeks or so. Advanced cases, early imaging in chest CT or bronchoalveolar specimen is important. Whenever we have bloodstream infections, it is important to repeat the blood culture after the initial positivity on day 4 to day 7. Whenever we have more than 10 days of positive cultures, it's important to check for infective endocarditis, like you have to do like transesophageal echo. When we have urinary tract infections in post-transplant settings, the best approach is to use antibiotics not more than 10 days. Whenever you can convert to oral antibiotics after day 5, you should attempt to do that. And when there is a persistent infection, we should try to use like local cystitis or any stones or anything in the kidney rather than continuing with antibiotics indefinitely. The most important and the difficult part in liver transplant patients is multi-drug resistant pathogens. We should involve the intensivists, microbiologists, all the physicians and transplant surgeons to form a combined approach. Source control is very essential. Whenever we see vancomycin resistant enterococci, complete workup with for biliary tracts and cardiac imaging is important. MRSA colonization monitoring should be adopted. Whenever you have MDR gram-negative ESBLs, isolation and decontamination is suggested. The common drugs used for these MDRs, few words about them. Linezolid and tigecycline can be used. They reach high concentrations in bile. But the problems with these medicines are they are often bacteriostatic. Tigecycline cannot be used in a high density ICU bacterial infection alone. It has to be with another gram-negative like meropenem and colistin. Linezolid also long-term has platelet toxicity and increases resistance. They have to be carefully used. Whenever you have gram-negative MDR bacilli, only based on sensitivity patterns you can use. You cannot use randomly a lot of antibiotics. Nowadays, we use a lot of IV colistins. It's often associated with severe renal toxicity, and we will be left with no medicine if you use colistin or polymyxin rampantly. In case of vancomycin, the levels are important. If the MIC is more than 2 microgram, should not be using it. The other antibiotics include televancin, but there is only limited data available. Especially, it's not to be used in kidney failure. To sum up, gentlemen, resistance in hospital-acquired infections is high. Irrational and overuse of antibiotics is a great concern. Start antibiotics only if definitely indicated. Always use first-line drugs, never go for second-line drugs. Develop a culture of culture. Select proper empirical antibiotics. Do not use antibiotics in non-bacterial conditions. It is important to have antibiotic stewardship programs in every transplant unit or a liver unit. It aims to measure and improve the antibiotic use. It not only measures the quantity but also the quality of antibiotic use. You have to have selection of improvement targets, and whenever you intervene with this objective program, the effectiveness of the interventions need to be analyzed and taken into account. Thank you, everyone.
Thank you, sir, for such a wonderful presentation. And I'm sure people would have learned from it quite a lot. And now I would request Dr. Karthik to share with us his thoughts on this topic.
So if the audience has some questions, they can ask, put it in the chat box.
Yeah.
We would love to answer them.
So if anyone has any questions, what we can do is, sir, or alternatively, what we can do is we take the questions at the end, if it's okay with you.
Yeah, at the end, they can put it in the chat box or send to you. We can take it at the end. Yeah.
Sure, sir. Sure. Please go ahead, Dr. Karthik.
Yeah, can I start?
Yes, sir. Please go ahead.
Screen is visible?
Yes, sir. It's visible.
So, good evening, everyone. So, greetings from MGM Healthcare. And today we're going to talk about special considerations in immunosuppressants and liver transplant. I mean, immunosuppression in general is a very dry topic. I mean, not many will be so inclined to listen to long lectures, especially when it comes to immunosuppression. But however, the entire game of transplant, or maybe any transplant, be it liver, kidney, heart, lung, everything, it all depends upon how you tailor the immunosuppressants. People say transplant is a science. And only when you understand the science behind it, which is mainly how to play and juggle with your immunosuppressant, it lies the success of transplant. Why? Because initially when we started transplant in India, I mean, we were all copying what the Western countries did. So in Western country, they usually, people keep a high immunosuppressant level of, TAC level of say 14, high steroid regimens, and we don't know how to play with it. When we tried to duplicate that, we had horrible results. We didn't even have 50% survival when we started liver transplant because every one of them succumbed to sepsis. So our Asian race, our Indian patients especially, they don't tolerate such high immunosuppressant levels as recommended by the Western literature. So that is why in this last 10 decade, we understood the game and we have tailored it according to our need. And still, we keep on improvising how to keep our patients very minimally immunosuppressive at the same time to prevent rejection and sepsis. So that's what the entire game is about. How to prevent organ rejection and also keep in mind how to prevent over immunosuppressing, thereby allowing sepsis or kidney injury to happen and let the patient slip away. You must have done a wonderful transplant 10 12 hours of living on a liver transplant, but entirely, I mean, when something goes haywire in the post-op, then everything goes for a toss. Yeah, so we're going to discuss the key points. Say, like, the main concerns are how to recognize the incidence of renal insufficiency after liver transplantation and the role of CNIs in nephrotoxicity seen after liver transplantation. Understand the potential role of certain induction agents, especially the so-called renal sparing therapies, in the later period after liver transplantation. And also in hepatocellular carcinoma, the role of mTOR inhibitors, which also play a pivotal role in preventing recurrence. And understanding the limitations of immunosuppressants during sepsis and how to tackle acute and chronic rejections. So the overview of immunosuppression is, so tacrolimus still remains the mainstay of immunosuppression in many centers, not only here, globally, still tacrolimus is the number one immunosuppressive agent which people prefer to use. For patients with pre-transplant renal impairment or slowly worsening renal disease after liver transplant period, we have to, because we know that, tacrolimus or CNIs are nephrotoxic. So how do we adjust it? That's what the entire game is when somebody's got a pre-transplant renal impairment or a post-transplant renal impairment or whatever it is. So reducing the CNI dose, and how low can we reduce it? And we always add MMF, that is mycophenolate mofetil, to prevent further rejection. And introducing sirolimus or everolimus. So nowadays people use more of everolimus than sirolimus. And in between 5-7 years back, there was an argument of start with everolimus and then switch over to everolimus. But now, since everolimus has been in use for quite some time, and people are much more comfortable with everolimus than sirolimus. And few centers where the patient has got a pre-renal HRS, where the creatinine is about 1.8 or 2, and the immediate post-op creatinine is still hovering around 2. You know that you can't start your CNIs for the next 4 to 5 days. So these patients, people have tried, and people are still using some centers basiliximab as an induction agent to tackle rejection and thereby allowing the kidneys to breathe. So here is the overall picture of various immunosuppressant drugs, just to recall your memory. And here is where your tacrolimus, the calcineurin inhibitors. So they inhibit the calcineurin pathway, thereby interrupting the T cell proliferation. And the other common one is the mTOR inhibitors, where you can see here by the JAK3 kinase. Both sirolimus and everolimus, they block the mTOR inhibitors. And your mycophenolate mofetil is anti-cell proliferation. So it acts at the cellular level. This is the overall picture for us to recall. And interleukin-2 receptor is your basiliximab, where is used as an induction therapy. And some patients will develop immunological tolerance following liver transplantation, may be able to stop taking immunosuppressant. This is what theoretically it is. But however, because of the risk of irreversible graft rejection, and because we have no tools to assess which patients are good candidates for stopping immunosuppression, so we should never recommend complete cessation of immunosuppression. With tolerance, we do talk about tolerance, especially in liver transplant, but till now, we're not able to achieve 100% tolerance in at least an average of even 10-15% also we're not able to achieve it. So the initial immunosuppressant regimen, there are different ways of looking at it. So this is the OPTN data, which was done in 2011. So a lot of centers, they do practice steroid-free immunosuppressant regimen, and most of them, see, that's why you see 60% of them, they do follow with steroids. And a few of the centers, especially in German, other centers, they do follow steroid-free protocols. And when you look at the period of time from 98 to 2011, how people have adapted. So initially people are using cyclosporin, and then we changed to tacrolimus. And then from azathioprine in those days, in late 90s and early 2000, and then again introduction of mycophenolate happened. And mTOR inhibitors, especially in the last 5-6 years, has been picking up. And steroids, like I said, depends upon the center variant. And when you look at the other induction agents, none of them are using it in the last 5-6 years, except for renal failure patients where you can't introduce an early CNIs. So the complications of transplant, we need to know, because these are also very important in understanding the game of immunosuppression. So acute rejection, chronic rejection, primary graft failure, biliary complications, hepatic artery thrombosis, and infections, especially viral and fungal, which are difficult to treat. And PTLD, which is an entity which we don't commonly see in liver as common as kidneys, but we do see it then. When you look at like patient in long-term follow-up, like more than 5 years, we do have slight incidence, about less than 5% incidence of PTLD, but in kidney it's quite high and it's quite common. So in general, what the immunosuppressant regimens guidelines, what they say is, here is the different consensus. So this is one published recently from Italian guidelines. So again, they introduce, in every center, they have a different protocol. Even in Italy or even in India, every center follow a different protocol. Some people, but most of them here are comfortable with triple regimen. That is a CNI and a steroid and MMF. So standard protocol in India, which is mostly followed in a lot of centers, is induction. It's always by steroids. So we give 10 mg per kg per body weight. Suppose the patient is 50 kg, we give 500 milligrams of methylprednisolone as induction in the operating room. But we don't start pre-operative tacrolimus. We wait for post-op. We start only in the post-op. The post-op is usually tacrolimus, MMF, and steroids. We do it as 1 mg per kg per day. That is day one. Say 50 kg, A male gets 50 mg of methylprednisolone on day 1 post-op, and then we taper it accordingly. So here what happens in case if, every individual it's personalized. So whenever a patient has got a very high risk, we can't give him 10 mg per kg. And some people still give 10 mg per kg, but we have seen a lot of sepsis episodes. So we tailor individually according to each and every patient's profile and their, and their disease profile. So we gradually taper steroids, except in special situations where the patient has got an autoimmune or, some people on HCV where we do not tend to rapidly taper their, steroids. And we target monotherapy, that is single immunosuppressive agent, by 6 to 8 months. At least 60 to 70% of the patient population are able to achieve this monotherapy, which is again, which is a good thing because it prevents a lot of metabolic complications later. And the advent of calcineurin inhibitors revolutionized solid organ transplantation. People started seeing 70% survival rate after the introduction of CNS. And thereby mitigating the risk of acute cellular rejection. Of course, there are side effects which are present, and that's why newer agents of mTOR, they all come into place to prevent this, what we call as metabolic side effects of long-term CNIs. Most common of the nephrotoxicity, it is most common and talked about. And hypertension, aggressive diuresis, pre-transplant renal insufficiency, diabetes, hyperlipidemia, hypertension, these are all the possible potential long-term complications which happen because of CNIs. And like I said, nephrotoxicity, I mean, there's another paper which quoted from a lung transplant also says nephrotoxicity is the most common long-term medical complication. And people are present, 26% of the patient present with renal dysfunction and chronic renal failure, about 6.8%, and 1.7% of the patients are on long-term renal replacement therapy. So they are like potentially a threat to the kidneys. So this is a standard protocol. So the green says it's a go ahead, and the yellow means, you have to like consider it's a caution is advised, and red means it's no. So this is about different protocols. And if there's a standard patient, say a patient is solid, good performance status, nutritionally well built, not much of sarcopenia, not multiple episodes of sepsis before transplant, and a low MELD patient, but fulfilling the criteria for transplant. So, I mean, do you go for a monotherapy? No. And how about a TAC and MMF steroid free? Yes, there are certain protocols and certain big centers use only steroid free regimen where they use only tacrolimus and MMF for the first 3 months. And another set where people have started introducing early everolimus. So after 1 week or 10 days of transplant, they combine everolimus and tacrolimus and they use. That is also has been agreed upon and people do use, and a lot of good results have been published. And caution is advised when you use CNI-free and everolimus monotherapy because we still don't know. Many centers are practicing that, so it's only a few data are there. So we can't totally 100% rely on it. And more than 3 months, again, TAC mono is not really advised at the end of more than 3 months to 6 months period. And TAC and MMF combination, you tend to keep a lesser level of tacrolimus trough level. So initially for the first 2 months, what we target the tacrolimus trough level is about 8 to 10. And more than 10, we don't need more than 10 for Indian patients. And after 2 months, we call it as maintenance phase, we tend to maintain a trough level of 5 to 6, which is enough. But again, it is not a strict thumb rule. Certain patients still need 7 to 8 TAC level post 2 months, depends upon whether they had any episode of rejection or it was a full-blown rejection or how they are behaving. Some patients do demand a lot of TAC level more than 6 or 7 despite 3 months or 4 months. So there's no set thumb rule. It's all, you gain experience and knowledge over a period of time. When you see thousands of post-transplant patients, then you develop your own protocol and then you can juggle around with these drugs and keep it safe for your patients. And like I said, the induction for CNIs, induction therapy is recommended to postpone the introduction of CNIs to 3 to 5 days. So at least if you have, especially when you have pre-transplant kidney dysfunction, where you can't start your CNIs in the first 2 to 3 days, then anti-interleukin 2 receptor blocker, that is basiliximab, which is being given on day 1 and day 4 in some centers, and some between, usually we follow day 0 and day 4. So we give like 20 mg per kg, 20 mg. And then you start tacrolimus on day 3 or day 4, depending upon the creatinine trend. So if the creatinine to start with, it's 2.5, and on day 3 and day 4 it has come to 1.5, 1.6, then you know that the trend is decreasing and there's no compromise in urine output, and now it's a safe period to introduce your tacrolimus. And of course, cyclosporin, in case if you're not comfortable with tacrolimus, the patient is too sensitive for tacrolimus, then you can switch over to cyclosporin. But however, tacrolimus is much superior to cyclosporin, but a lot of neurotoxicity, we might be forced to change from tacrolimus to cyclosporin. So when patient develop neurotoxicity or neuropsychosis, then we stop tacrolimus and then introduce cyclosporin, which is again the choice if the patient has got much of neurological issues. And again, we target even when in such patients where there is pre-existing renal dysfunction, we don't target high level of TAC. It all depends upon his everyday creatinine level and his urine output measured. So it's ideal to start 3 to 5, and then you push depending upon the need, depending upon the enzyme levels and how the patient clinically is looking. And we do some centers, like I said, they do have a steroid free orientation, but if steroids are given, like I said, it's 10 mg per kg per body weight, and then you taper according to the disease. And everolimus, I mean, people do start, even we also started introducing everolimus, the first after the first 3-4 days. I mean, after the first week, then, we do, sometimes we are forced to introduce everolimus after a week of transplant for a lot of reasons, because you're not able to push your tacrolimus, not able to give much of steroids, and the billy is not coming down. The enzymes are still stuck at a level. Then you are forced to introduce everolimus. And of course, there are 2 cautions which we need to be precautionary about it. One is the HAT, another one is the hernia, which is the wound healing problem. So after a week, I think it's safe to introduce at least a low dose of tacrolimus, see how the patient's LFTs are responding. So one thing which you have to check before introducing everolimus is to check the proteinuria levels, because if the proteinuria is more than 1 gram, then you cannot introduce your everolimus. And mycophenolate also has certain criteria where there shouldn't be much of pancytopenia. We don't give, we withhold mycophenolate if the platelets are not building up more than 25,000, or there is hemoglobin is always 7, and the WBC count is less than 2,000. So we don't, we withhold mycophenolate because it's an anti-cell proliferating agent. And so immunosuppressant in critical patients, this is what we need to concentrate and talk about. So we categorize such patients before liver transplant. So there's no fixed protocol, like I said in the beginning. So we always tailor it case by case basis. It's very challenging in deciding day-to-day doses. Like I said, with the over period of experience, because this theoretical knowledge alone cannot drive you to, decide the day-to-day doses in immunosuppressants, especially immunosuppressants, because as you see more and more patients, as you see more and more transplant patients, that's why in large program, when you get trained large volume program, you know how they juggle around. There's no fixed things. So it's by experience, you get it every day when you decide the doses, when you see the different LFT pictures, different sets of patients, where somebody will be like sepsis and there'll be rejection, go hand in hand, and how do we treat it? It all depends upon your day-to-day practice. And so what are the critical patients? So somebody's got a high sodium melt, and somebody's weight listed as a high risk, and people with sarcopenia and frailty, and who had recent episodes of acute GI bleeding, or immediate post-op they develop some kind of GI bleeding, renal dysfunction, HRS, sepsis, or recent SBP or multi-drug resistant bug colonized anywhere, or portal vein thrombosis patients, and metabolic syndrome, thoracic ascites, UTI or ventilatory support, or any inotropic support is going on, or any high-risk surgical for any other issues. So these patients are categorized as critical patients. So in critical patients, usually they'll be too weak to reject, but that doesn't mean that they will never reject. So these patients, you can play low key. You need not keep them, the tacrolimus level of 8 or 10, or you not push them so much of steroids. And in general, the good thing about liver transplant is we don't find hyperacute rejection. The rejection usually starts 5 to 7 days, because it takes 5 days at least for the preformed antibodies to recognize and then start attacking. The first 4-5 days, we never see rejection, or mostly, because very rarely we see antibody mediated rejection, your C4D cluster. So, but in the liver, acute cellular rejection is what the majority is, and it never happens before 5 days. So you still have time to build up your TAC level. And critically ill patient, especially with high sodium melt and sarcopenia, believe me, they hardly tend to reject. So always play low, don't keep them high TAC level, because highly immunosuppressing them will definitely push them into multiple episodes of sepsis, septic shock, and then eventually we'll lose the patients. So you got to be very careful whenever you have any high risk patient or sick patient undergoing transplant. The post-op is, you might have done a very beautiful surgery with minimal blood loss and everything, but your patients, if they do not tolerate the immunosuppression, they will succumb to sepsis. And even after 3 months, it's good to keep them. Immunosuppressants are never targeted on trough levels. You need to keep them as minimal as immunosuppressed to prevent rejection. That should be your ideal goal. So that's why we keep periodically checking the LFTs, their enzymes and the bilirubin to see if there is any jump in the enzymes. And if there are no other identifiable cause for the increase in enzymes, then you know that, probably is rejecting, so he needs more of immunosuppressant. And patients with specific etiology, there's always some consideration for that. And especially when there's a combined liver kidney, whether we need to go for a standard protocol or you need to have a renal sparing protocol, it all depends upon case to case basis. So, and other thing is patients with autoimmune disease. So the autoimmune disorder, they can never be steroid free. We need to always have some kind of steroids on board, at least from 2.5 or 5 mg for lifelong. And any kind of HCC patient. So here where the role of mTOR inhibitors. So usually previously we used to start mTOR inhibitors, sirolimus only 2 months after transplant. But now we are seeing recommending early start of everolimus. And this is again the same for more than 3 months. Like I said, HCC patient in particular, we always introduce the mTOR inhibitor to prevent recurrence. So that's why the high risk at native histology or relapse, then you go for a totally CNI-free everolimus monotherapy is also justified when a patient has got an HCC. It depends upon his tumor profile and AFP and your PIFCA scoring and etc. And this is again the same thing. So the patient with onset of de novo malignancies or patient with extrahepatic cancers or PTLD, again, everolimus monotherapy after 2-3 months is still recommended and there's a green signal for it. And in these patients, if you still want to use both tacrolimus and everolimus, it has been cautioned. So the choice of immunosuppressive regimen in liver transplantation should account a composite of clinical variables, including the primary disease and patient status at transplantation, the type of surgery, DDLT, LDLT, or whether you've done a Roux-en-Y or duct-to-duct, the early post-operative, even if there's any bleeding, bile leak, or a portal vein thrombus, or something is happening, and there is an chylous ascites, on expected complication associated with long-term use of CNI, namely the acute and chronic renal failure and de novo malignancies. Strategies for prevention or limitation of CNI-related adverse events should be implemented as early as possible following transplantation. And it all again depends upon the patient's clinical status. At present, the most effective nephroprotective strategies include the reduction of CNI exposure, facilitated by the early introduction of everolimus or mycophenolate, because some centers they're reluctant to use mycophenolate on start. So you can always combine everolimus and mycophenolate, like how you combine tacrolimus and mycophenolate. And there is an increasing need for renal sparing immunosuppression, especially when I say, a sicker recipient or an older recipient where the kidneys cannot tolerate much of exposure to CNIs. Several promising strategies has been time and again tested. And presently, CNIs continue to have a pivotal role in immunosuppressive regimen in every patient. And like I said, so what kind of nephrotoxicity does CNIs introduce? So they lead the kidneys to irreversible renal interstitial fibrosis, leading to impairment in function. So at a histological level, they go into interstitial fibrosis of the renal cells. And tacrolimus can be advanced over the decades. Target troughs have been reduced, but still CKD is still an issue. So that's why people are slowly switching over to everolimus to prevent these kind of complications. So now everolimus is gaining popularity and is being accepted worldwide, even as monotherapy. It has been completely replacing, tacrolimus. So protecting the kidney and liver transplant is always a point of concern for all the transplant surgeons. And the key points and recommendations recently there is no high quality evidence supporting any renal protective intraoperative interventions. Resuscitation with intraoperatively with HES and chloride liberal fluid should be avoided in liver transplant recipients. Some centers, so even when we started transplants in Medanta, I mean, like in 2000s and late early 2000, we were using HES, and then after a period of time, we completely stopped using HES, and now we are completely moved to plasma light and other more physiological solutions along with albumin to prevent more burden to the kidneys. But some centers do HES and other colloids, so which can be detrimental to your kidneys. So there are promising biomarkers of renal injury available for study to detect early AKI, which may ultimately lead to targeted strategies to avoid significant post-operative renal injury and CKD. And we'll skip this slide because we already talked about it. And we also mean there is also an tacrolimus extended release, where instead of a BD dose, that is a twice daily dose, we use only a single day administration. And there's no formulation approved for the use. But however, narrow peak trough differences, unlike with the BID dosing, it improves the adherence because the compliance is better with patients because they have to just pop only one pill a day. They don't have to take 2 pills a day. So this lot of lack of compliance has been overcome by this extended release tacrolimus. And with increasing time in therapeutic range may reduce adverse effect exposure. So when there is a borderline kidney injury, you are reluctant to introduce everolimus, you can try this extended release tacrolimus and see how the kidneys are behaving. And again, we did talk about this induction therapy, basiliximab. So basiliximab, like I said, it's an interleukin-2 receptor blocker, mainly used in the early postoperative day 0 and day 4. And it has been demonstrated by, so this is what it is. I mean, I think this is enough to understand. I don't want to get into the details of the entire study. And so sirolimus and everolimus, keep in mind they are non-nephrotoxic and it's a replacement for CNI. And before introducing them, always check for proteinuria. And if there's no proteinuria, and then you can safe to introduce the mTOR inhibitors. So everolimus, apart from the sirolimus, also has an anti-neoplastic agent, which is why we prefer using it in HCC patients. And how do they act in this HCC patient? How do they help us? They prevent the angiogenesis. And they block the angiogenesis and thereby they prevent the recurrence of tumor. And it's been time and tested again, and it's been recommended for all HCC patients. The result of everolimus inhibition of mTOR is a reduction in immune cell proliferation. And solid organ transplants, liver and kidney, everolimus is an mTOR inhibitor immunosuppressant indicated for prophylaxis of organ rejection, like you know. And kidney transplant, low moderate immunological risk, and liver transplant administered no earlier than 30 days. It's an older concept, but now people have been using everolimus even 5 days or even a week after transplant. So dosage will skip. And drug interactions. So to summarize this, several strengths and limitations of the potential renal sparing agents and regimens. So there's no definitive renal sparing regimen. Still need to be tailored for the individual patient for maximum benefit. There's a saying called no one size fits all approach. The need for carefully designed and conducted trials are still there. And personalizing immunosuppression, narrow therapeutic index, the limitation. So the limitation is because some people, even with 1 mg of TAC, their trough level shoots to 20 or even 16 or 18. But on board, you will see only 1 mg twice a day. This is because of the genetic polymorphism which exists in every population. People do test the genetic polymorphism of gene cytochrome P450 of 3A, depending upon, because some patients will demand more TAC. And despite being 4 mg twice a day, the TAC level will be still 6 or 7. So it depends upon genetic polymorphism of the cytochrome. And tackling rejection is again a big task here. And that's what we're going to talk about now. So, we'll talk about acute cellular rejection. So before you term any patient as rejection, you always prove it by a biopsy. And why? Because we don't want to rule out any other infectious sources or a bile duct or it is any other ongoing problem. And acute cellular rejection, once it is then, the first choice is the pulse steroid therapy. So high intravenous doses of steroids, typically referred to as pulses, reverse about 75% of acute rejections. There is no good evidence that higher pulse doses, more than 500,000 for 3 days, are more effective than low pulse doses. We always stick to lower pulse doses because again, our patients don't tolerate high dose of steroids. And if somebody, our protocol is to give 250 to 500 depending upon the patient's profile. We give it for the first 3 days and then we start tapering. And whenever we start anybody on pulse, we upgrade the antibiotics. We also add an antiviral, especially to tackle the CMV, so that we protect our patients from any kind of infection. And if somebody goes in for a steroid resistant rejection, that means despite trying 3 pulse doses, then you term it as steroid resistant rejection. Then you go for other methods like plasmapheresis or ATG or IVIG. And the other tricky one is the last part, which we're going to talk about, is sepsis versus rejection. It's always a double-edged sword. This is the most difficult part of post-transplant management. It needs to have a fine balance whenever you have a sepsis and rejection, because you need to treat both hand in hand. You cannot neglect rejection, cannot neglect sepsis. If you neglect any of these, it will be detrimental to the patient. The overall clinical picture needs to be considered whenever you treat sepsis and rejection. At 30%, 25 to 30%, you will be landed up in the situation where the patient has got some mild sepsis and there is also some rejection going on. Especially even the biopsy also shows that, there'll be a neutrophilic attack and also there is a lymphocyte proliferation, around the graft. So that means you have to treat both hand in hand. So you got to upgrade your antibiotics, find the source of sepsis, keep the immunosuppressant, as minimal to moderate, mild to moderate is what we would do. We cannot overboard because we need to treat both and see how the clinical response, how the patient is behaving, and then you step up accordingly. Let's skip this. So operation tolerance is what everybody talks about it, but off lately in the last 5-6 years, throughout the world, there are some anecdotal reports are there, but nobody is able to do a complete withdrawal of immunosuppressants. 20% can be weaned off, they say, but we have never seen, we have never touched, especially in India, we never touched 20%. I would say it's still about less than 5% tolerance. And because we don't want to be in a situation where there's going to be a chronic graft rejection. So the favorable factors are long duration after transplant, advanced age of transplantation, and male gender. Even if at all you want to try, say like the patient is post-liver transplant more than 10 years, he's already 75 plus and he's a male, then you can think of tolerance and start withdrawing the immunosuppression, closely follow up and see. So we come to the end of the talk. So it's always need to be a balance. It's like a balanced diet. So now the floor is open for questions.
Thank you very much, sir, for such a wonderful and illustrative presentation. I think it was such informative as well. So we do have a couple of questions, maybe with your permission, sirs. May I start with Dr. Tyagarajan first? And there were 1 or 2 questions which are there. So Dr. Tyagarajan, is it okay? Should I go ahead?
Yeah.
So this question, sir, that do you see now Zivisefta, which is a combination of ceftazidime with avibactam, as a potential game changer in the antibiotic segment?
So I would say nowadays a lot of people have been started using this ceftazidime avibactam nowadays. This is like similarly what's been there to colistin maybe 4-5 years ago, when most of the things were resistant to antibiotics. Colistin was the only thing available. Now colistin is being rampantly used, so we don't see that much resistance to ceftazidime avibactam. Even though ceftazidime avibactam is a good agent compared to the traditional cephalosporins and the KPCs, Klebsiella producing carbapenemases, still it doesn't act against the metallo beta lactamases. So I think we have to use it selectively. It's a good antibiotic. If we start using it quite rampantly, we are going to face the same fate as colistin. 3-4 years down the line, it's not going to be effective. As of now, it's an effective antibiotic used very reservedly. It can change the game, but if you often change the game, you lose the game.
Then there is another question possibly, which means is how do you view the role of cefepime-tazobactam combination.
Yeah, when you take cefepime-tazobactam is like old wine in a new bottle. So you have cefepime, you have tazobactam. When you commonly, piperacillin tazobactam is the workhorse. So it's been used for generations and the resistance is quite prevalent. So under cefepime, they thought it's easier to combine with tazobactam, so they've come up with antibiotic. It works. The spectrum is better than the piperacillin tazobactam, as equivalent as sometimes exceeding the carbapenemases, carbapenems, but still it doesn't act against the metallo-beta-lactamases, which is a scourge of Indian um antibiotic scenario. It has a potential to be carbapenem sparing, but again, you have to use it judiciously. It's definitely, it might be better than piperacillin tazobactam.
Thank you, sir. Dr. Karthik, there is a question now which may possibly implies that how do you view the role of sirolimus now? The fact that it has a black box warning in liver transplant, and then it impacts the wound healing. So how do you view the role of sirolimus in the your scheme of things in liver transplant?
Yeah, see, sirolimus per se, we don't call it as a potent immunosuppressant. We always couple it with tacrolimus. And especially sirolimus, we never start, because of this black box warning, we never start sirolimus in the first. That's why I said sirolimus, when we started using sirolimus, especially for HCC patient, we always do it 2 months after transplant. That's when we introduce it. But however, everolimus, they do have the same side effect of wound healing and all those things are there. That's why we always use everolimus with the caution. And at times we are forced to use it for various reasons. Like I said, we are not able to continue with tacrolimus. The bilirubin is not coming down when there is no other reason for the jump in bilirubin or enzymes. Now we introduce everolimus at least after a week after transplant, and we always start with the low doses like zero point 0.5 BD and then slowly build up, see how it is. And when you do 0.5 BD for 3-4 days, the wound at least heals by 10-12 days. The wound at least healing is much better. So, and then we start building the everolimus level. So, sirolimus per se, we don't recommend that as a potent immunosuppressant. It can't be a replacement for tacrolimus. So, everolimus, however, is much better. And again, we always see the cautionary of not using it before a week's time at least.
And with the permission, I would just want to understand, especially in the patients with renal insufficiency, would that be a category where you would prefer to use a combination of tacro with everolimus, maybe immediately 1 month down the line?
Yes. Whenever there is a possibility, especially after 1 month, the creatinine is still not settling down, and for various other reasons, we don't mind introducing a combined regimen of tacrolimus and everolimus.
And generally, what would be the target level that you would keep at, both tacro and evro put together?
For the first 2 months, like I said, 8 to 10, they both put together. And after 2 months, we would try to maintain it 5 to 7, again, depending upon the patient's profile and how he is tolerating it. See, the ideal aim is to prevent rejection. So even with the low the lower trough level, there are certain patients who are still having a TAC trough level of 4, and they were never rejected. So we leave them like that, but we closely monitor first 2-3 months how the enzymes are behaving. If for the first 2-3 months, if they have accommodated to the same TAC level of 4 and they're not rejecting, so they are unlikely to reject in the future. So they are okay with 4. But again, it's not a thumb rule. It all depends upon patient's profile, patient to preference.
Dr. Tyagarajan, there's one more question which says that how do you manage the fungal infections in your unit specifically, and what's your opinion on posaconazole since it has a better safety profile?
Basically, fungal infections, it depends on
It got disconnected.
It looks like sir has got disconnected with us.
Wait for him to come back.
Yeah. Yeah, so I think we lost a connection with you.
Yeah, suddenly I lost connection.
Okay. Yes, sir. Please go ahead, sir.
Can you hear me?
Yeah, we can hear you now, sir.
So fungal infections, we have a commonly fluconazole prophylaxis, but other than specific fungal infections, as empirical therapy, we use anidilafungin or micafungin, and generally other fungal therapies based on the cultures. Fungal infection, especially based on the cultures. Persaconazole is a second line therapy. It's not a first line therapy. It has a better side effect profile. In mucor and all, we use syrup persaconazole as a second line when somebody is renal toxic, but generally we don't use it as a first line.
Right, sir.
It's not very highly effective.
So, sir, Dr. Karthik, there's also another question that in patients with HCC, underlying HCC, what would be your preference? Would it be sirolimus? Because I guess maybe in Vedanta you had a long series of patients on sirolimus, or now everolimus in the wake of later.
Everolimus.
It will be everolimus.
I think in 2015 or 2017, 18, we started moving to everolimus. And again, it took 1.5 years for us to completely move over from sirolimus to everolimus. And we are the largest series of HCC, and Dr. Jayaran also was a part of the HCC.
Okay.
So it took some time for us to completely trust in everolimus.
Okay. Lastly, sir, I have a question from a company's perspective, and I wanted an insight from both of you being the experts in this. Do you, at the moment, I mean, this is a more of a feedback to us, sir. Do you, as of now, face any treatment gap from a molecule perspective that we as a company can rope in or, explore to market in India, or currently something? Is there a treatment gap?
Yeah, you can consider this bortolizumab, belatacept. I don't know how much common it's and how much is the cost. They have some side effect profiles. Actually speaking, like antibiotics, immunosuppressant, tacrolimus came long back. Still into wider clinical use, we don't have a better, it's effective drug, but it's quite a toxic drug.
Okay.
So a lot of problems with that. If we can have a better drug with a lesser side effect with the same efficacy, either if you have a lesser side effect, then the efficacy goes down. If you have equally efficacious and lesser side effect profile, I think there's a huge scope in immunosuppression thing. The last 20 years, I don't think a new molecule has been discovered which can match up to tacrolimus in the efficacy.
Efficacy.
Yeah, and has a lesser side effect profile. I don't have personal experience in the belatacept and the bortolizumab, but I've been hearing few stories about them. We are yet to use them.
And anything you would suggest, especially in NASH?
Means NASH medicines.
NASH.
Yeah, definitely this obeticholic acid and all these new drugs, they are very exciting. I think it's not commonly available in India. So I think it's a huge scope in India. You should bring that. All the new NASH medicines.
The NASH load is quite high in India.
Okay.
Yeah, it has a huge scope. Yeah, definitely we should bring them up. Because it at least reverses up to grade 1 to 2 fibrosis. It's been quite effective recently. Maybe 1 or 2 agents. So maybe we need to have them in India.
Thank you very much, sir, for such wonderful insights. And indeed,
Yeah.
thank you very, very much for this enthralling session. I mean, I'm sure audience would have benefited a lot from it. Thank you, everyone, the lovely audience, for having tuned in for this webinar. Thank you, both of you, Dr. Tyagarajan and Dr. Karthik, for this wonderful, wonderful webinar. I thank both of you from the bottom of my heart. And of course, we'll continue to have more such meaningful interactions in the future as well. Thank you very, very much, and a lovely evening ahead.
Thank you. Thank you.